بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening. Actually, today it's going to be really a special opportunity for me personally to present and share together with my colleague, Dr. Majid Zubaidi, the President of Cardiac Emirates Society, this STEMI Taskforce Symposium, which is going to throw some glimpse over the STEMI management in the Northern Emirates and in general in United Arab Emirates. This is really going to be a hot topic, and we have been discussing this the past decade and trying to improve a lot of kind of strategies to cover all areas in the United Arab Emirates. Certainly, we have been going through a lot of challenges in this. Before getting further, I'm Arif Al-Nouriani. I'm an interventional cardiologist, by the way, and currently I'm heading the working intervention group in United Arab Emirates. And I would like to present a couple of slides as part of our future strategy. Mrs. Reem, if you go to the next slide, please. I don't know if we can see the next slide. Yes, next, please. So, next. About an Emirates national kind of registry, the slide, as we see that we know that the sea elevation myocardial infarction in major cause of morbidity and mortality worldwide, nothing new for us, but much of efforts devoted to the management of STEMI, including primary percutaneous coronary intervention, thrombolysis, and early PCI, post-thrombolysis, or hybrid strategy have been instrumental in such changes. Primary PCI, a form of free perfusion therapy, is an extremely important and valuable treatment for ST elevated myocardial infarction. Next, please. So the importance of this strategy actually was because we know that there's indisputable scientific evidence behind myocardial revascularization, and the STEMI is life-saving. It reduces mortality and recurrence of heart attack, heart failure, and stroke as compared to the previous standard therapies, which used to be the pharmacological in the first line using thrombolytic therapy. Initiating this treatment rapidly, ideally within 2 hours of a STEMI, is really the key to prevent long-term damage and improve the outcome. The accessibility of STEMI patients in UAE to this life-saving management is not very clear and not well known. In line with this international guidelines and applications in diagnosing and treatment of cardiovascular diseases, the interventional working group of the Emirates Cardiac Society decided to start creating and implementing a national research work and informational study that would include all hospitals and centers across United Arab Emirates. Next, please. So from here, our aim is to capture all the relevant clinical information of patients, including their attack onset and symptoms and other clinical parameters, enabling us to improve our knowledge on the risk, burdens, obstacles, and outcomes of real-world patients with this clinical condition, and finding answers further for specific questions of high clinical relevance using the information collected. Next, please. So I would like to use this opportunity here to invite you all to attend the online launching of our ECS National STEMI Registry, and certainly your interest and encouragement to this, to the physicians and your healthcare providers of your STEAM departments and organizations will have a great impact on the success of this important study and the specialization in our beloved country. Thank you. So from here, I would go and move further to introduce our panelists for today. And I would like to introduce Dr. Muhammad Salah as a consultant cardiologist from Kalba Hospital, Dr. Mundir Al-Fitlawi, consultant cardiologist from Sheikh Khalifa Medical City Ajman, and Dr. Abbas Ahmed, consultant cardiologist, Sheikh Khalifa General Hospital, Al Quwain. And really, it's going to be a great opportunity to have two from emergency departments joining us also, which will be introduced by Dr. Abdul Majid soon. So, Dr. Abdul Majid, if you could take over. Thank you.
Thank you, Dr. Arif, for your kind introduction and for the initiative of of trying to gather data on STEMI, because this will help guiding our future decisions towards addressing this critical condition and improving the care of these patients. I'm honored to be part of a group tonight from my colleagues from the Northern Emirates, Dr. Arif, Dr. Kamel, Dr. Naeem, Dr. Fabricio, Muhammad Salah, Mundir, Abbas, Dr. Hishmat. So all the guys are, doing a great job. There is a lot of good work happening there. So we thought of this, such an educational initiative would bring most of us, and so we can share our experience and learn from each other. So I'm going to give you a brief about, this initiative from Abu Dhabi side, and then get the experience of the rest of the colleagues from their point of view, either it's an emergency department or it's a cardiology and a primary PCI like Ras Al Khaimah, Al Qasimi, and Fujairah area. So STEMI patients, we all know, they don't present, they don't know if they have a STEMI. What they know is they have chest pain. So they can present to anywhere in within the healthcare system. They can present to an ambulance service. They can present to a hospital where there's no cath lab, or to a clinic, or to a hospital where there is a cath lab or there is a primary PCI site. But our job as a healthcare systems is to have a system that brings this patient to the care, to the best standard of care, which is primary PCI. And as you can see, this slide from the European Society of Cardiology guidelines of managing STEMI, and it does show you where the different modes of presentation, but at the end, all these patients should be receiving a primary PCI if possible. The guidelines and the different professional societies are encouraging that patients should be, the communities and the groups should come together to coordinate the care of primary PCI. This is not a one-man or a one-institution job. It's everyone has to be there. You can see in this document by the AHA, you have the ambulance, you have the emergency, you have critical care, you have cardiology, and you have the EMS, so have a society of thoracic surgeon. So everyone has to be on the table to streamline the care of this patient. For example, in Abu Dhabi, this map, I brought it out of the Department of Health website, and I tried to map the population of Abu Dhabi to the map. So if you look at Abu Dhabi and you divide it into different regions, the central, the western region, and then the eastern region, you see most of our population are localized in the areas where there is a facility. So 63% of the population of Abu Dhabi resides within this area, and then another 25% here, and the rest are in the remote areas. Now, if you look at these two areas, there is a multiple cath labs, primary PCI 24/7 is available. So so it's just a matter of how can you streamline, how can you ensure the access of patients who comes to any of these hospitals. These hospitals, they, those dots and those icons represents different healthcare facilities, clinics, and small hospitals. So the patient can present to any of these, and the key is, our job is to ensure that this patient can get a care into a primary PCI site, can be transferred in a timely fashion. So a lot of hospitals, as I said, a lot of providers. So how can you coordinate the protocols and develop a protocol that makes these hospitals work together and these centers and clinics work together? How can you engage the payers and the insurance companies to ensure that this is not, the care is not delayed while trying to get a financial clearance? The same thing in the Northern Emirates. I've been honored to work with colleagues in the Ministry of Presidential Affairs Initiatives hospitals, and a lot of good work had been happening there. And now I'm hearing also from, or we're going to hear from Dr. Arif and his team in Sharjah how much good work is there is done over there, and we'll hear from Dr. Hishmat how work is done or this how STEMI care is streamlined in the East Coast. So still there's a lot of challenges. I mean, we need to have an integrated healthcare system to take care of such patients like STEMI, stroke, and trauma. We need to avoid random transfers across facilities. We need to have protocols. We need to eliminate or work on the competition among healthcare providers. We need it to be a healthy competition rather than and focused on the patient. So the patient should be the priority of us if we are to compete. And the providers, they need to get to the regulators and work with the regulators. Financial challenges, we need to address them. Of course, we have a lot of patients who are not insured. And of course, we have variation in standards that we need to work on and bring it together. In Abu Dhabi, we had this set in the public sector, at least not within the private, long time back, as where we set primary PCI as the standard reperfusion for all patients with STEMI. And we divided our regions as I showed you. This is only the public sector. The previous map I showed you includes the private and the public. Here, this is the public only. And what we did is we divided these into regions. So the island region, and or what we call the middle region, eastern region, and the western region. And then we unified. At that time, every hospital has its own protocol. Some were 24/7, some were working hours only, and some had thrombolysis. And over time, what we did is we created the shared rotas, developed protocols, and finally we're able to ensure that in at least more than 90% of our patients within the region of Abu Dhabi are receiving primary PCI as a treatment for STEMI. The remote areas continue to have some or continue to have a pharmacoinvasive protocol. So we had a task force, and the task force responsibility was to work with the regulator to ensure that we have regulations and indicators that monitor care for patients with STEMI. The payers are involved, the EMS service was involved, different providers and different healthcare professionals, and also the community was involved. This is some of the documents we worked with the regulator to develop, and which is defining receiving centers and referral centers with the according to the AHA documents, and where we define the responsibilities and the roles of every institution, either it's a referring site or it's a receiving site. We also worked on a document on EMS system. This was a long time back as to where the EMS should drive patients. A lot of educational activities for the healthcare providers, for physicians, nurses, front-end staff, EMS personnel. This is a picture of some of the our colleagues from Abu Dhabi ambulance services visiting the cath lab, where they come, they have attend lectures, and also they visit, they CCU, and they units. And continuous education have been part of our work with the all the different healthcare professionals. So in conclusion, I think we need to move forward. We need the national registry, as Dr. Arif stated at the start. We need to have more educational initiatives to the public and to the healthcare professionals, and also to the different stakeholders like the EMS and the regulators. We need to standardize protocol across. We need action plans for perceived barriers to care. Public and private sector collaboration is very important. And quality metrics, we need to standardize them across the country. So everyone, when we talk about door to balloon or door in, door out, everyone talks the same language. The EMS is very crucial in this, in such project. And in December, I think we're having a focus on pre-hospital care for STEMI patients. And also public education is very important. So that's what I have. I'm going to stop sharing, and of course we'll take questions towards the end of this meeting. But I would like to move now to our next speakers after this brief talk. And I think our next speaker is going to be Dr. Fabrizio Clemente from SKSH, from Sheikh Khalifa Specialty Hospital in Ras Al Khaimah. And Dr. Fabrizio is the head of cardiology there, and they're doing a great job in terms of taking patients for primary PCI, either those patients that they receive and those who are within their region. So Dr. Fabrizio.
Good evening, everyone. I hope you can hear me.
Yes, we can.
So many thanks to the Emirate Cardiac Society about this opportunity to be here with you. And I'd like to thank in particular Dr. Abdul Majid for his effort and support during the last 5 months. He really was a mentor and a real guide for building our network here in the Northern Emirates. First of all, we have to ask ourselves one fundamental question: why really we need a network to treat STEMI cases? At the very end, the treatment of acute coronary occlusion is giving reperfusion, either pharmacologically or mechanically. And this can be achieved in any hospital. If you have a cath, you use mechanical reperfusion, else you only need to give a drug. Years ago, it was 1979, Raymer and Jennings demonstrated that there is a wavefront of necrosis proceeding from the subendocardium to the subepicardial in a time-dependent fashion. And from their pioneering studies came the famous equation, time is muscle. And muscle, when it comes to the heart muscle, means survival. And this relationship between mortality and reperfusion time is undoubtedly real for the first few hours after an acute coronary occlusion. The more the hours from the event, the least will be the steep of the relationship. Gaining even 30 minutes in the very early phase dramatically will improve the outcome. And as you can see, there is a significant increase in mortality for every 15 minutes of delay past the 90 minutes of reperfusion. And thus came the ACC and ESC guidelines that recommend that fibrinolysis should be provided within 30 minutes and primary PCI within 90 minutes for first medical contact. So, given this steep relationship, we can ask ourselves, why do you need to transfer and delay treatment option for cases presenting a non-PCI capable center? And this is a legitimate question. Indeed is the same problem the primary investigators of a landmark trial in reperfusion therapy, the Dynamic 2 trial, were asking back in 19th. Shown here are the main results of the trial. The primary outcome of the trial was a composite endpoint of death, recurrent MI, and stroke, showed a relative risk reduction of 45% in the trial. And this was true both at sites non-PCI capable as well as in the PCI capable center. And recently, the 16 years follow-up of the regional trial registry has been published in the European Heart Journal. This figure clearly show that primary PCI gave a substantial advantage over fibrinolysis in terms of rehospitalization, NMI, and cardiac death at 16 years. And the curves continue to diverge over time with not late catch-up phenomenon. So more important than all these figures and numbers is one here, 114 minutes. This is the mean door-to-balloon time in the DYNAMI-2 trial. It is important to note that those benefits of primary PCI over fibrinolysis are real only if we keep the door-to-balloon time low. But how low? We have to keep it. This question was addressed by Pinto back in 2011. He reviewed and analyzed the National Registry of Myocardial Infarction 2, 3, 4, and 5. Those registries collected patients from 1994 to 2006 in the USA for a total of more than 100,000 cases. It was clear that any delay related to primary PCI count and the maximum benefit in terms of mortality achieved when the delay associated with primary PCI is below 60 minutes. And yet, there is still a benefit with a delay of more than 90 minutes. And the crossover was found around 120 minutes. So let us go back to our original question, why we need a network for STEMI. This guy here is James LeBrown. He's 4-time NBA champion, 4 times NBA most valuable player. He is one of the all-time best scorers in the NBA. Yet, he could have never afforded any title without a good team around him. He scored the final point, but the LA Lakers, Miami Heat, and Cleveland Cavaliers team with him to win the NBA. Even though the interventional cardiologist is the one who finalized the reperfusion, achieving this reperfusion in a timely fashion needs a tremendous team effort. Patients, EMS, emergency department have to work as a single entity, cutting every available minutes out of the reperfusion clock. That is why you need a STEMI network to improve the regional outcome for the STEMI. But how do we build and how do we analyze the network? The analysis starts with the comprehension of the time frames and where your time delay is. There are delays related to the patient, to pre-hospital transport, in-hospital management, and reperfusion treatment of choice. You can address all these delays, and everyone has a different solution. At patient level are media campaign and patient education. Pre-hospital transport requires EMT to obtain 12-lead ECG on the field with direct transmission to the hospital for diagnosis confirmation. In-hospital management requires a continuous effort on focus of all the ED staff on the importance of fast ECG acquisition in any presenting chest pain and prompt recognition of ST elevation by the ED physicians. A single operator call for cath lab activation and a straightforward process for ambulance boarding for inter-hospital transfer. PCI centers need to accept the patient directly in the cath lab bypassing the ER registration, and cath lab staff need to be in the hospital and ready to receive the patient in no more than 10 to 30 minutes. Every single step needs a predefined maximum acceptable time frame with continued review of every single cases recorded to remove unpredictable barriers. You need a maximum acceptable time for door to screening, door to diagnosis, door in, door out, and finally door to balloon. If a case will not meet the maximum expected time, and an in-depth review is mandatory and addressed altogether to be fixed. Continuous effort is the key to success here, and this is a team effort. Network success is a systemic success. Feedback about the time saved is crucial and give a tremendous boost to the quality of the whole system. So let us have a glimpse of our STEMI population of the last 12 months. Most of our cases were male with an average age of 49 years. Diabetes and hypertension are the most represented risk factors. Smoke was present in nearly 40% of cases. Culprit vessel was LAD in 55% of cases and left main intervention done in 2.4% of cases. We reach 57% of complete revascularization during the index procedure and in 1/4 of cases, the PCIs was multivessel. The radial approach used in more than 93% of cases. In nearly 85% of cases, the PCIs was primary, and we did 7% of rescue PCI. Nearly 1/3 of the population was from UAE and 1/4 Indian, and those was the maximum represented population. So how many minutes could we reduce the door-to-balloon time with the implementation of our STEMI network? Before starting the standard protocol and in-depth analysis of our procedure and pathways together with our sister hospitals, we couldn't record the door-in given the absence of a consolidated inter-hospital network. So we decided to collect the time of STEMI referral to our on-call cardiologist as a reference for our STEMI clock to count. And we collected it not only for the SKMC Ashman or Al Quwain, but even for Sakar and Saif Hospital. And as you can see here on the blue bar, the mean activation to balloon time was around 114 minutes from cases referred from Ashman, 90 minutes from patient referred from Al Quwain, and 95 from Sakar Saif Hospital. The red bar represents the same time frame collected during the STEMI network implementation program. The data here include all the cases done since the beginning of the process, and it is immediately evident that we saved 16 minutes from Ashman and 25 minutes from SKGH. Sakar Saif hospitals, where the STEMI network was not implemented yet at the time of the analysis, is displayed as the comparator. And 5 minutes was saved even for patient referred from those hospitals as a general improvement in patient handling in our hospital. If we analyze the data along the last 2 months from implementation, we can see that day by day, correction after correction, review after review, the door-to-balloon is plummeting. In the last 2 weeks, we reached an average of door-to-balloon for referred cases of 94 minutes, with all cases below 120 from first medical contact to balloon. Door-to-balloon for transferred cases was below 90 minutes in 60% of our cases. And this is an outstanding result. So what's next? We will extend our network to Ibrahim hospitals with shared pathways and protocols and continuous review of their referred cases. We are trying to include our emergency medical system in the network with ECG acquisition in the field and direct transfer of patient in PCI-capable hospital, considering that at least half of the cases were transported to the ED by the emerging medical system. Extension of the network to all Northern Emirates medical centers, and certification of our network by the American Heart Association. Thank you for watching.
Thank you, Dr. Fabrizio. Yeah, please go ahead.
Go ahead, Dr. Arif. Sorry.
Thank you, Dr. Fabrizio. That was really very impressive, the data you presented over the past year. And I believe Dr. Abdul Majid deserves what you have said also. His support was highly appreciated. So from here, we'll move forward network by Dr. Profsty and head of cardiology department at Fujairah Hospital. Dr. Hussain, go ahead.
Thank you, Dr. Arif, for the kind introduction. And thanks for Dr. Zubaydi for this wonderful gathering. In the coming 15 minutes, I'll be showing the network that exists on the eastern coast on the Gulf of Oman region for acute myocardial infarction. And I'll be discussing some overlap with Dr. Clementi. Why do we need the STEMI networks? And how did the network in the East Coast evolve? What's the flow and the pathway of patients who present with myocardial infarction to non-PCI centers. This will be the focus of the talk, the current situation and what are the current challenges and the future perspectives. Just a small reiteration of what Dr. Clementi said. Why do we need STEMI networks? Because if patients with MI, if they're not revascularized, the mortality rate will be sky high. And now there's no argument that primary PCI is way superior to fibrinolysis. It saves 50% extra in addition to that being saved by fibrinolysis. Depending on where you practice in cosmopolitan, metropolitan cities, there's a cath lab enough for everyone. So patients with MI can be easily treated, but in other geographic regions where the distance between the cities is a bit high, then primary PCI will not be readily available for every STEMI. That's why the alternative here will be fibrinolysis. And this is based on some trials that show that fibrinolysis, if given pre-hospital, can be non-inferior to primary PCI, although that comes at the cost of more bleeding and more cerebral hemorrhage. So if PCI is not readily available for everyone around the clock, then a combination of thrombolytic therapy and PCI seems to be the logic solution. And again, why STEMI? Now, if we look at the ASC guidelines, it's explicitly mentioned as a class 1A that the care of STEMI patients should be based on regional networks. So there should be networks based on the region where the patients live. Again, the guidelines reinforce that there should be STEMI management protocols shared within geographic networks. So myocardial infarction is a peculiar disease in this regard. So how is it going worldwide? It's a slow process, but it pays off. And it takes years and sometimes it takes decades until you see this improvement. In France, it took them almost 15 years to increase the utilization of primary PCI from 12% to 75%. In Austria, 2 years to just get 11%, 20% more. In China, it took them 10 years to increase the rate of primary PCI from 10.6 to 28. So this is a long-term endeavor that will take not just months, it's expected to take years until the systems become fully mature. The challenges are obvious, of course. The previous speakers alluded on that. Myocardial infarction is a lethal disease. Unlike a patient with cancer who can be given an appointment to start chemotherapy, a myocardial infarction patient cannot wait. It involves multiple disciplines, emergency department, internists, general practitioners, and the cath lab is a sophisticated environment. These are critical patients, and transferring these critical patients is guarded by hazards. And if you're receiving a patient from another center, then you're not seeing the patient on your own. So it's difficult to transfer the real situation of the patient to a receiving center, especially when there are different hospital environments. A hospital may have a cath lab, the other may not. A hospital may have cardiac surgery, another may not. So if we look at the map in the region, so you can see that there is a cluster of, there is a cluster of cities here in the region, extending between Oman in the north and in the south and Ras Al Khaimah in the north. And this part of the UAE is at a relative distance from the other big cities in Sharjah, in Dubai, and in Abu Dhabi. And looking at this region, there are only 2 cath labs and 5 or 6 hospitals that have cardiologists or have internists, and they don't have cath labs. So what happened in Fujairah Hospital? The cath lab was there for 9 years. In February 2018, we started operating the lab 24/7, and we started accepting STEMI directly to the cath lab for those patients who present to our emergency department. And we built the system slowly, so that after 6 months trying and reiterating and correcting our mistakes, we started to systematically accept patients with STEMI who were referred to us from other hospitals. And then 3 months later, 4 months later, we started to work on our KPI of first medical contact to wire crossing, and then several small improvement projects trying to improve the care for these patients. And then we had to regulate the process with developing a guideline, an official guideline for inter-hospital transfer. And this started via a series of meetings with doctors in the region. We had to sit with doctors from the surrounding hospitals and explain to them what are the problems, what do they need to do, document, understand the care class, and if the patient is a frail patient, we can discuss the conservative options. We need to get a clear understanding of the comorbidities, need to communicate properly and document everything, and think of the referring process. It's a multi-tier process, doctor to doctor, and nurse to nurse. Logistics are transferred through the ambulance.
Vedo come inizia. Certo dormo bene, perché se dormo su e mi svegliano dormo bene, poi.
I think we need to mute some of the audience.
Background noise that needs to be muted.
Yes. And initially, we had this thought that if we think that the patient can be transferred within 30 minutes, then we'll accept him for primary PCI. And if not, then we'll give him the fibrinolysis and then send him. Later on, we came to realize that the logistics of admitting the patient to a hospital and then discharging him from he had to be discharged from the hospital. It was not just a transfer. So we realized that the process would take definitely more than 30 minutes. So we decided systematically that when a patient presents to a non-PCI center, that he will not be transferred immediately for PCI. He will be managed by fibrinolysis, and then he will be transferred to the PCI center. And we formulated this in a general guideline with the help of the administration and with the help of the quality department. This guideline was developed in late 2020, and it's due for revision now. It applies for all patients with STEMI and even the very high risk acute coronary syndromes. And we divided their journey into 7 phases, where they are diagnosed, where the communication starts. Then there's the transfer process, the admission, handover, the management, and the communication back, and then the transfer back. And we tried that our document would be detailed in every single step in the process, anticipating at least 2 scenarios. One of them where the patient will be accepted for a full hospital stay, and the other one where the patient will be accepted as an on-pass, where he just performs the procedure and then he goes back. And then we had support from the IT department and from the electronic medical record to create a workflow that facilitates the process of transfer. And I'll be showing just a number of the patients who came from non-PCI centers in 2018 and 2019. We had 70 patients with STEMI who were referred from the sister hospitals. As we know, the majority of STEMI patients are males, and the 7 females were mostly from the Dhiba region and from near the Fujairah Masafi region. And these are mostly elderly females with lots of comorbidities and multi-vessel disease. The majority of the population of patients are from the continent, and a significant proportion of Emiratis and minority in numbers from other nationalities. And we know that the age in our region is 10 years younger than in the Western Hemisphere. The mean age of our patients is 50, standard deviation of around 12. The youngest patient is 23, and the oldest patient was 90 years old. And as I mentioned earlier, initially we had the enthusiasm that we can take the patient directly for primary PCI if the hospital is a 15-minute drive. But later on, we decided to defer this and focus on timely administration of fibrinolysis and effective and fast transfer to the PCI. The barriers that we note these are the barriers that are noted worldwide. There's nothing peculiar. The transmission of the ECG, the human resources, the facility of the ambulance, the administration process of admission and discharge, the reimbursement policy is usually taken care of till the point of inserting a drug-eluting stent instead of a bare metal stent, where here there will be some reimbursement issues. So how can how are we looking forward to improve the system? I'm a personal believer in the lean methodology, where you look at the value, and the value here is time. So we need to work on shortening all the possible times. Probably pre-arrival activation in the ambulance. The ambulance needs to communicate with the PCI center, and probably should be able to share the data some way, telephonic or through internet, to share the ECG to the PCI center, and maybe administer the pre-hospital thrombolysis. And then there's no need to send MI patients to non-PCI centers. Patients are preferably channeled to the PCI centers. And there is a need to integrate the PCI centers so that if one is blocked or down, then the patient will be channeled automatically to the other PCI center. And as the previous speaker said, this is no one-man show. I would like to thank all the doctors who shared in this wonderful endeavor, Dr. Amr, Dr. Amrish, Dr. Thaer, Dr. Hassan, and the wonderful team of nurses and technicians, Mirvet, Vivian, Mona, Ahmed Rakish, and everyone. And of course, the hospital administration, who was very supportive in the initial tough days where we had issues in logistics and etc. And to me, STEMI is the holy grail of cardiology. This is the field where we can really save lives more than any other procedure. Thank you so much.
I don't know, Dr. Arif there. So I think our next speaker is Dr. Kamil Valaba from SKMCA Ajman, and a very attractive title here in front of us, Chasing the Balloon, Clearing the Path to Optimal STEMI Care. Dr. Kamil.
Thank you, Dr. Abdul Majid, for the introduction, and good evening, everyone. It's indeed a pleasure to join you for this webinar from Cape Town, South Africa. And a huge thanks to the Emirates Cardiac Society, Dr. Abdul Majid, and Dr. Arif as well, and to our sponsors for the invitation to reflect on our experience over the last couple of months as part of the Northern Emirates STEMI Collaborative, aiming essentially to improve STEMI care in the region. So I work as a consultant emergency physician in the emergency department at Sheikh Khalifa Hospital in Ajman. Ajman is the smallest but most densely populated emirate in the UAE, and our hospital covers a catchment area of roughly about 500,000 people. Our emergency department visits exceeded over 70,000 pre-pandemic, and we continue to manage a high burden of both acute and chronic cardiovascular disease. We see a lot of STEMIs at SKMCA. This year alone, we have seen just over 150 cases. SKMCA unfortunately does not have a cath lab currently, and our STEMI patients are referred to PCI-capable referral facilities in the surrounding emirates. Now, prior to the initiation of our collaborative, we presumed our patients were receiving optimal care. ED was quite proficient at diagnosing STEMIs and contacting the medical team early. Patients were then discussed with our PCI referral hospitals Sheikh Khalifa Specialty Hospital in Ras Al Khaimah or Al Qasimi Hospital in Sharjah and transferred for PCI. If they were not accepted, and this was mainly due to bed availability issues, they were liaised at our facility. So we're, however, not analyzing our data, so we had no idea how we were truly performing. The majority of patients were able to access primary PCI, but were they actually getting PCI within the recommended 120 minutes? So was born the STEMI Collaborative Initiative in late August under the leadership and tutelage of Dr. Abdul Majid, and together with colleagues from our sister network hospitals, SKGH and SKSH, we have worked really, really hard over the last 3 months to improve STEMI care in the Northern Emirates, with the main goal of ensuring that all STEMI patients have access to primary PCI in a timely fashion. We have done this with the mindset of a STEMI systems of care approach, with the aim of improving a collection of integrating processes and pathways to identify and treat a patient with a STEMI. Even within our own facilities, we've all had the opportunity to evaluate our referral process, review the referral and transfer paperwork, and evaluate data by measuring specific time metrics. Daily review of the collected metrics and weekly meetings within the network facilities have ensured we are constantly looking for opportunities to innovate, improve, and involve our processes and pathways. Our collective vision is aligned, and that is to ensure that all STEMI patients receive primary PCI as the gold standard of care in line with international best practice. Now, prior to the STEMI Collaborative Initiative, I must admit that I never really bothered much about the referral process. I mean, through the lens of an emergency physician, I was just pleased that our patients were being diagnosed with STEMIs timeously, and we were alerting the medical team rapidly. What we as a department chose to see was our medical colleagues getting on the phone, discussing the case, and then joining the patient a few minutes later in the ambulance on the way to a PCI referral center. What we didn't see was the myriad of activities that needed to take place before a patient eventually departed the hospital. Referral pathways were, however, fragmented and inconsistent. Patients with STEMIs were sometimes transferred to SKSH, Al Qasimi Hospital, and even private facilities. Our colleagues from medicine initiated the referral conversation, and sometimes our in-house cardiologists were called upon to make the referral. So while the majority of patients eventually got to the cath lab for PCI, we actually had no idea what their outcomes were. Some STEMI patients received fibrinolytic therapy as a reperfusion strategy, and this was mainly due to bed unavailability at the referral hospitals. So we needed some baseline data to judge how well we're doing as a referring facility, and started by looking at the last 2 quarters of the year and calculated that our average door-in, door-out time was an astounding 83 minutes. Now factor in the travel time to SKSH, which is approximately 35 minutes away. This would obviously impact the door-to-balloon time, and Dr. Fabrizio earlier commented that the average door-to-balloon time pre-collaborative was over 2 hours, not in line with the recommended target of 120 minutes for a patient presenting to a non-PCI referral center. So I needed to look at our own processes to try and identify opportunities to improve our referral times, and started by mapping out the process that was required to get our patient out of our ED on identification of a STEMI. And it truly looked like a tangled mess of micro processes. So this was the end result of the exercise, and a really convoluted and complicated series of events turned out that involved many phone calls and many people. So just to walk you through this slide, if a patient presented through our doors with a STEMI or STEMI equivalent, the patient was obviously seen by our emergency department physician. Once the STEMI was recognized, the internal medical doctor on call needed to be notified. The internal medical doctor on call needed to call the SKMCA cardiologist to discuss the case. And often, if the SKMCA cardiologist was not available, or if the referral was somehow not successful, the SKMCA internal medical doctor would need to call the SKMCA cardiologist, and he would need to discuss the case with the cardiologist at SKSH. After hours, the process was even more confusing. The medical doctor on call at SKMCA had to contact the emergency department specialist on call at SKSH, and he or she had to communicate with the SKSH cardiologist on call. If the patient was accepted, this was then transmitted to the SKMCA ED nursing team leader, who then started to mobilize the SKMCA ambulance and also inform the SKMCA ED nursing supervisor that the acceptance had been granted. The SKMCA ED nursing supervisor then had to inform the SKSH bed manager or the ED coordinator after hours, who then had to also confirm with the SKSH cardiologist on call that the referral had been accepted. This then led to the ED nursing supervisor informing the ED nursing team leader, and finally, the patient departed SKSH. Phew. Okay, so what we decided to do was just have a look at our processes a little bit deeper and analyze all the microprocesses in an attempt to eliminate all the unnecessary and redundant steps. So we first started by ensuring that SKSH would remain our exclusive referral facility within the network. So we eliminated the right-hand side of all these processes. The next step was to try and eliminate all the redundant steps and all the unnecessary people that were involved in this referral. All we needed to do was just call one person on the other side who accepted the case, and then we were good to go. So finally, through a process of refinement and more refinement and more refinement, we finally got to a much more streamlined and simple referral process. So this is our new streamlined STEMI referral process. What we also did was create a STEMI alert within our own facility, and that involves alerting all the relevant stakeholders once a patient arrives with a STEMI or STEMI equivalent. We then call the SKSH cardiologist on call. Once the patient is accepted, the patient departs to SKSH. And we set ourselves a target door in, door out of 30 minutes. So our in-house STEMI alert ensures that all the required people, paperwork, and processes start and run in a parallel manner on identification of a patient with a STEMI or STEMI equivalent. The emergency physician calls a STEMI hotline and is connected to the on-call interventional cardiologist directly. The ECG is then shared on MS Teams, and the necessary referral sheet and ECG copies simultaneously uploaded onto a shared folder accessible to SKSH. We've also protocolized the immediate medical management of STEMI equivalents to ensure timeous and consistent administration of the required medication prior to transfer. Our own ambulance, together with the transfer physician, is on deck on initiation of the alert, ready to commence the interfacility transfer. So in the space of a few days, we're able to take an extremely convoluted, tangled process and simplify it simply by eliminating unnecessary and often redundant steps. Minimize the paperwork required for referral while still ensuring the medical, legal, and patient safety aspects were met, and essentially created a beeline to the on-call interventional cardiologist. All these improvements have led to a dramatic decrease in the door in, door out time and eventually door to balloon times. So in summary, the last 3 months have resulted in a streamlined referral process. Once again, we've eliminated redundant steps in the referral process and all the unnecessary paperwork. We've created a single phone number for referral and a standardized referral form between the facilities. One game changer has been the fact that bed availability is no longer a rate limiting step in the referral. Microsoft Teams has been set up as a platform for communication and feedback, which is important in terms of us knowing what has happened to the patients, and shared network folders between the network hospitals to share all the essential documents. And these interventions have led to a decrease in our door in, door out times from an astounding 83 minutes to around 30 minutes in the space of 12 weeks, which I believe is truly remarkable. So optimal patient outcomes for STEMI care can be achieved by strengthening and optimizing all elements in the context of a system of STEMI care. The patient, emergency medical services, the emergency department, and the referral hospital all play an integral part in ensuring that patients have good outcomes. Thank you.
Thank you, Dr. Kamil. That was really quite impressive data that you presented, and you made it quite simple after getting so much confused with all those changing things there, but you managed to come out of it. And you got the balloon finally somehow in the hand, so congratulations.
That was the aim. Thanks, Dr. Arif, appreciate that.
Really, congratulations for you and the team. So we'll move forward and from here, and then we'll leave the questions later on to the next speaker. So we have on board now Dr. Naeem Touzi, Sheikh Khalifa General Hospital, Al Quwain, and he's emergency medicine consultant. So please, go, Dr. Naeem.
Okay, there we go. Can you hear me, guys? Hello?
Yes, sir. Clear.
Thank you. Thank you. Yeah, just to start, I'd like to congratulate my colleague and friend, Dr. Kamil, for catching the balloon. You know, it's been a pleasure working with the whole team, and I'd like to start by thanking everybody for being here, and also saying how an honor it is to be invited by such a specialty group for such a prestigious meeting to present some of our what we've done over the last several years. So I think it's an interesting contrast, and I think you will notice, and it's probably good for all the participants to see that there's several approaches, and our approach was actually quite different to Ajman. So we've not made any rapid changes, but it was a systemic approach. So just to sort of contrast and compare a little bit. So I'm Dr. Naeem Touzi. I'm UK trained emergency physician working at Sheikh Khalifa General Hospital from I think 2014. For quite a few years. Okay, just forward. It's not. Hasn't moved forward. Why is that? Okay. So just to mention, I think people have mentioned the geography. It's important to note that with the UAE, you've got Abu Dhabi, which is a very big area and has its own challenges, as very clearly mentioned by Dr. Abdul Majid. But if you look, I mean, in the Northern Emirates, north of Dubai, or just there's a lot, 5 different Emirates. Some of them are different sizes; they vary, and that creates its own sort of challenges. The northernmost Emirates is Ras Al Khaimah, where I live, and obviously we work in Al Quwain, which is just south of that. And these Emirates are known for their sort of sporty outdoor activities, particularly in tourism. Okay, so just, this is appropriate. I would just wanted to mention, as we're in a pandemic, it's just important to notice that, and this is the point I wanted to make, that it's really important for people to notice things, to observe, be observant. And, if you're observant, you start noticing things which could be improved or could have problems. And this in particular case, I'm just mentioning, it was during the plague in 1666, when Sir Isaac Newton was sitting in his mother's garden, looking at the planets and thinking of motion, and then the apple fell down, and that's the story anyway. And he wondered why the apple fell down and not went sideways or any other way, and then obviously that led to his sort of description of gravity. Or the forces of gravity. So a simple observation can result in big change. And I think Dr. Hussein Hishmat mentioned Kaizen, and Kaizen is a Japanese principle, but what it means is change to become good or to become better. So you're always constantly looking at ways to change, to improve what you're doing, and it's about continuous improvement, as it says down there. Furthermore, this is sort of what happens. You've got a measure and you've got time. And what you do is you start observing and changing small things, make improvements. And then sometimes there's bigger jumps, and then you continue to improvement, and there's further jumps. But overall, the process is such that you make significant improvement over a period of time. So in this, following this principle, and we've been, me and my team So, you know, great credit to all my team, including nursing team and all the other specialists and admin who support us. But we've looked at loads of different things. You know, myocardial infarction, ischemic heart disease is one. We've improved processes with major trauma. We've looked at safety of patients with, you know, review of cultures and, you know, VT prophylaxis, for example, for lower limb immobilization, and other diagnostic aspects of our care. So, you know, we're looking at many things at the same time, balancing, trying to improve all the time, seeing what we can do. But in this symposium, obviously, we're talking about myocardial infarction. We worked on different aspects of that, but obviously, what we're really going to concentrate on right now is the early access to primary PCI. Okay, I mean, what's the importance of this? And, you know, I think we all mentioned statistics, but what's more powerful than statistics is often a story. And this gentleman, you can see he's actually a first cousin of mine, who's a surgical director of solid organ transplantation in Boston. Just last month, I think, or a couple of months ago in August, he suddenly passed away, presumably of an MI, while leaving early in the morning, going to do a transplant. You know, obviously Harvard was very sad. He was quite a senior surgeon, did a lot of things. You know, their flag is flying at half mast on the right. And what it shows is that, you know, you can lose a very fruitful life very suddenly of a preventable illness, really, or preventable and treatable illness. You know, and that not only deprives that person and his family of, you know, a fruitful life, but also potentially many patients, for example, in his case. So this is really important, and you can see, and I think people have mentioned, I won't belabor this, but every 30 minutes of delay to reperfusion increases the 1-year mortality significantly. So this is the importance of this thing, and you know, obviously, I joined in 2014. So this is our emergency department, just outside door. And you can see this is the timeline of things that happened. I'm showing the gradual improvement. In 2014, when we joined, there was no formal STEMI transfer arrangement. STEMIs, as my colleague Dr. Khamid has mentioned, were referred to internal medicine or ICU, depending on how stable they were, and then transferred mainly to, at that time, the Qasimi Hospital. And in the year after, in 2015, the SKSH opened, and it's got a cardiac center. So we saw the opportunity there to improve the care our patients were receiving. And we actually, a big team of us, including our cardiologist, CMO, head of medicine, I can't sort of mention everybody, but you know, we all went to SKSH and had a big meeting with the cardiologist and agreed on a plan for primary to transfer, rapid transfer. You know, and we were still doing transfers to both Qasimi and SKSH at that time. And after we agreed a pathway, we implemented it. You know, and this was in collaboration. We had a lot of discussions with the medical director of National Ambulance at the time as well. So they were doing a pilot study for STEMI bypassing the Northern Emirates, or in Ras Al Khaimah in particular. So you know, there's a lot of discussions with Fergal at the time, with Professor Fergal Cummins, who was an emergency physician, and we moved on. And you know, I stole this slide from Kamil, or borrowed it actually. He gave it to me, so this was permission. But you can see our process wasn't that dissimilar, and it was very convoluted. So I just wanted to show that. And you know, essentially all of these steps on the top are referral steps. And then all of these are transfer steps, you know, and you know, there are only 2 processes really, but it's taking, you know, significant amount of time. And this was our very early chest pain pathway. I've left it small intentionally so you don't read it, but you can see that this was all chest pain, so including non-STEMIs, and the STEMI bit is in the red on the right. So it's much simpler. And this was in 2016. And you can see this is the top end of this protocol, and you can see that if a patient has an early ECG, they meet the STEMI criteria. We call at that time we're calling the emergency medicine consultant who connected, and send him the ECG. He sent it on to the cardiologist, and then if the expected time to balloon was less than 120 minutes, then we gave them a standardized cocktail of drugs agreed with Sheikh Khalifa Specialty Hospital and transferred the patient using internal medicine. So you know, it was a hybrid process, but it was all agreed and it worked pretty well. And you know, it's not that simple as just to put a protocol out. Obviously, what you need is to implement it. You have to take a lot of steps. And we had support from our hospital management, you know, foremost, and then you know, we empowered emergency physicians to make the diagnosis. Previously, they suspected the diagnosis, but got it confirmed by internal medicine or cardiology, even in clear cases. And obviously, we created a clear transfer arrangement, so there wasn't much negotiating at the time. If your guy was stable, he would go with the internal medicine, ICU covered the ward, or if he was unstable, ICU, a doctor would, or anesthesia or ICU would go with the patient. And then we underpinned all of this with education for our team. So, and this was thank you to, I think, our panelist, Dr. Abbas. He had several seminars over the weekends at that time, talking about how management of ACS. And then we had an ECG workshop, thanks to a group called EM ECG. And on the left, actually, is Dr. Kamil again. So, you know, he was part of our process, even though he's actually working in another hospital. So, you know, it's a teamwork that way. You can see that this is our process map after, fairly simple. You know, after diagnosis, we send the ECG, it goes to PCI, cardiologist, we activate transfer, and, you know, it goes to ED and then cath lab. I mean, this is a simple process, but actually it could be simplified further, you know, and the steps for referral have been considerably decreased, and the transfer steps have been considerably decreased. And what actually happened, you know, this is something I want to show, that our first sort of 8 to 10 patients pre-protocol, so right here, so these are, this was, you know, their door-to-door number. At that time, we were measuring door-to-door times, because what I thought was important was, or what we could measure, the last time we could measure is when we dropped the patient off at the PCI center. And you can see these numbers are not very, very good. But then very quickly after the protocol, you can see that there's a dramatic decrease in you know, door-to-door times. And this line actually above and below is 90 minutes. So most of these patients were dropped off within 90 minutes. Obviously, we didn't have at the time any timestamp for what happened at the PCI center. But we, you know, we persisted. I just want to show that, so this is the same statistics before and after. You can see our mean time was 137 minutes before, with this is the range. And then post protocol, it dropped to 73 minutes. Even, you know, even the longest time to door time was actually a minute, just a minute longer than the shortest time before the protocol. So it just shows you the effects of having a standardized protocol. And then it has other effects. And this is what I wanted to show, that before the protocol, the ED doctor was making a diagnosis or decision in 25% of the cases. And the decision to transfer was made, it went up to 87.5, so almost 90% of the time, the ED physician could make that diagnosis accurately. And, you know, and I actually reduced the transport time, and just to sort of come in line with what our current measures are. So before the protocol, it was 99 minutes, door in, door out. So that long, an hour and a half or more than an hour and a half, and then 44 minutes after the protocol. So less than half. And, you know, just, I'm not going to belabor this, but you can see that our figures are similar. Our UAE figure for STEMIs is slightly higher, probably than because of the way the demographics is. It's about almost half the patients. But the Indo-Pakistanis are younger generally, with higher risk factors. Average age is 52. But, you know, the thing is, if you do it you know, it's impressive what we've done. I think it was impressive, but the thing is that it's hard to sustain over the years. And you know, if I looked at 2019 and 20, you know, our average times got crept up from 44 to about 56 minutes. Still well below what it was, but not ideal. And it's because some of the challenges we faced over the years were, as I think has been alluded to by some of our other presenters, that there was a need for a period, there was a discussion on need for financial undertakings of the patient. You know, availability of ICU beds was always an issue, or occasionally an issue. And then obviously in the last year, COVID-19 has meant, you know, do we do a test and a sample before? Do we send the patient without? And what happens with that? But, you know, our ambitions have always been that patients we should refer directly to the cardiologist, not through ED. and then transfer straight to the cath lab, and that will save a considerable amount of time. And that's where, you know, I think the STEMI network has come in, and, you know, over the last few months, that's really empowered and recharged everything. We have weekly meetings with all the stakeholders. We've developed a form with a referral form with brief documentation to decrease documentation, and also have formal timestamps of every single thing, sort of our symptom start, arrival, when the diagnosis is confirmed, when the patient's transferred, and when and then the form goes along with the patient, and then as the PCI center and SPSS fills in the other measures. So we have an accurate group, and this is the overall pathway. So there's a pathway for referring hospital on the left, and a pathway for receiving hospital that has been developed through the network. So the achievements, I think, you know, that I've seen over the MOPA network, and there's probably many more, is that there's been a clear mission and leadership. So, you know, with the prime principles, you know, of accepting all patients independent of ICU bed status and financial status. Obviously, the communication has with the PCI centers improved with rapid link through a hotline, and confidential transfer of data through Microsoft Teams and FTP. Also, what's happened with these weekly meetings is weekly reviews of the timestamps of cases, so that things can be discussed and looked at, and, you know, problems can be addressed. And obviously, in the recent weeks, there's been a broadening of this discussion of the network to include teams from Ras Al Khaimah, DOH hospitals, and Al Qasimi or Sharjah, and also including National Ambulance. And also, there's been discussion on accreditation of our PCI center or formation or joining a registry. So just final couple of slides. You can see that Quain is slightly unique in that most of our patients are coming by private vehicle, 84%. And you can see that even the National Ambulance data tallies that with only 2% of their total patients being coming from Quain. Although, you know, our population is small, but this is a disproportionately small percentage. And, you know, I think my colleague Kamil, Dr. Kamil spoke about we're very different, you know, they're all Northern Emirates, but they're very different challenges. And Ajman is a highly densely populated emirate with the, you know, while Quain here, you know, we've got about 3 times the area, the size, but only a seventh of the population, which actually means the density of population in Quain is almost less than a 10th or 11th of Ajman. So it's a completely different challenge. And, you know, so I think our challenges, and I'm just not going to talk about ourselves, but it also probably applies to others, is educate the public. You know, I mean, I think people don't realize it's not traffic here. So people in Ajman, people are calling the ambulance because they're afraid, I think, that the traffic will make it difficult to get to the ambulance, or get to the hospital. But in Quain, you know, there's not that much traffic. So people think I'm much quicker. Why should I wait for the ambulance? But they don't realize the added value of an EMS system. And that's something we need to do. And recently, I think the emergency medicine community is very excited because the UAE has passed a Good Samaritan law, which means that we can start educating our public on early recognition, you know, cardiopulmonary resuscitation, and maybe access to early defibrillation, so that you know, we can improve the community response. And then we, you know, explore something we call pre-hospital bypass to PCI centers. But there are several administrative challenges to that, and we'll come to that. And although, you know, as the National Ambulance already published in Ras Al Khaimah, as I mentioned, the feasibility of bypassing and how successful that can be, and including diagnosis by paramedics fairly accurately. And then the other thing, I think the challenge we need is establishing a teaching and a case review forum for doctors in the Northern Emirates, that we can review all cases. So I'm just here that am I jumping in joy for you know, for the future. And if there are any questions, then I think they will be answered at the end of the seminar. Thank you very much. I'll stop here.
Thank you very much, Dr. Naeem. I think accept my deepest condolences about the passing away of our dear colleague, Dr. Khalid. That was really very sad, what we heard about it. Feeling very sorry about this. And thank you for the nice presentation. And allow me to move forward to our final speaker, Dr. Bassam Al-Baba, consultant interventional cardiologist from Al-Qasimi Hospital. And that will be our final. Then we follow that with the questions, please. Dr. Bassam, please.
Good evening, everyone. My talk today, I will try in the few coming minutes to share with you our experience regarding clinical pathway for management ST elevation myocardial infarction in our facility, Al-Qasimi Hospital. You know that Al-Qasimi Hospital is located in Sharjah, which is the largest governmental hospital in Ministry of Health, and our cardiac center is a referral center for the primary PCI 24/7 since long time. Average monthly primary PCI cases, it is about 40 cases per month. The North Emirate include 5 emirates, as you know, and more than 60% of population are reside in Al Sharjah Hospital among all population in the North Emirate, and about 20% of population are local, and 88 are non-local, and aged of population, 55% of population are between age 20 and 39. As we are a referral center for primary PCI and ST elevation management, so we try to enhance our service regarding managing patient with ST elevation to provide high quality comprehensive medical service to ST elevation MI. And for that, we are trying to translate clinical international guideline to clinical practice pathway to improve and standardize treatment of patient with acute ST elevation myocardial infarction by promoting evidence-based practice and to reduce variations in the care provided and to minimize mortality, morbidity related to acute myocardial infarction, and to monitor the outcomes and compliance to acute myocardial infarction pathway. And when we start to create this pathway, we get our scientific information from the latest version of the European Society guidelines, which is 2017 regarding ST elevation myocardial infarction management. Then we add the update, which is released at 2018 regarding revascularization. Our strategy of reperfusion in Al-Qasimi Hospital, it is primary PCI. We no more use thrombolytic therapy in Al-Qasimi Hospital, and we aim to achieve diagnosis to wire time to be less than 60 minutes for all comers directly to Al-Qasimi Hospital, and for referral cases to be less than 90 minutes. As you know, the no more European Society of Cardiology use door to balloon. Since 2017, they canceled this from the guidelines, and they recommended the use of diagnosis to wire time, because as per European Society, that 20 to 25% of patients coming with ST elevation, MI is a presentation, it will be not clear enough to diagnose. So they recommend the diagnosis time, not the door time, to wire time since 2017, but still used in American Society of Cardiology door to ballon. To create a clinical pathway, according to the information from the European Society, as I mentioned above, we start to create this pathway and this clinical pathway. To mention this clinical pathway, each step of medical management or medical service should be afforded to any patient coming with ST elevation MI. And first we start with hard copy, and we review this hard copy many times through 3 months, and we adopt this pathway many times to be applicable and to be practical. Then after this trial of 3 months of manual applications of the clinical pathway, we convert this to electronic documentation. So clinical pathway for ST built in the Cerner, which is the Mohab electronic documents. After confirming the diagnosis at ER, we activate this pathway in the Cerner, and later on there is 3 steps of activation. First step should be done in the ER by ER physician. Second step by cardiologist for our team, and then the third step of activation it will be after finishing the primary BCI and starting to shift the patient to the observation area. After activation of the pathway, all points that should be followed and should be afforded for patient services and patient management will be clear in the system, and either automatically for some point regarding for medication in the ER, regarding lab test in the ER, or manually for many of steps. So in this electronic documentation and this pathway, we unify the service or the medical management, the management of all patients coming with ST elevation MI. And any missed point in this pathway will be noticed and considered as a variance. So any variances in this management will be audited and monitored, and we have regular meeting every month to calculate these variances and to put action plan for why these variances must happen. For example, if the patient should be discharged after 3 days for ST elevation MI, if the discharge not happen after 3 days, this is the variances. We have to explain why this happened. For any variances in the management will be noticed and they will be clear in the system, so we can audit it and noticed and monitored. This is the hard copy, which I mentioned before, which is tried for 3 months and adapted many times, which then we converted to electronic pathway in the system. What is the target population we are serving for ST elevation according to the ST elevation European Society guidelines? We recommend the same recommendation for defining patient with ST elevation myocardial infarction. I will not repeat, this is clear for all of you, the definition of ST elevation myocardial infarction. Our continuum of care, it will start in the at the presentation in triage of the patient to do ECG for less than 10 minutes, then cardiac on-call informed directly by ER physician and diagnosis made and clinical pathway activated. Then patient, once clinical pathway is activated, we start, and after the team is available, all the team in the cath lab. We start shifting the patient to the cath lab to do a primary BCI, and then we keep the patient for short of time in the recovery area in the cath lab. Then we shift the patient to the observation area. Through inpatient, once we activate the clinical pathway in the ER or consultation regarding other teams, regarding physiotherapy and regarding pharmacists, regarding nutritionists, regarding education person, all will be activated in the system to be done later on in the second day of admission for all patients. And then after discharging the patient, we give the patient appointment in the clinical rehabilitation, in the multidisciplinary team clinic, which include rehabilitation clinic and psychiatric and nutrition and physiotherapy and nurse educator. In the same room, they are doing clinic service in the same time, in the same clinic, within 4 weeks of discharge. And we success to do this distinct multidisciplinary clinic. Also, the patient will give appointment in the cardiac clinic, also different clinic within 4 months of discharge. This is patient age category. We can recognize here that most of our patients are between age 30 and 60 years in our facility, and the distribution of gender, 95 of ST elevation MI patients are male and only 5 patients are female. As we mentioned, regarding our clinical pathway, one part of our clinical pathway is that we have KPIs to monitor our achievement, and we have many KPIs, and according to these KPIs, we can monitor our achievement and make auditing for this and make and put action plan regarding each KPI. The 4 KPIs which initially we recommended is that diagnosis to wire should be less than 60 minutes. Second KPI, it was in-hospital mortality rate after primary BCI. And the third one, it is percentage of patient with left ventricular ejection fraction more than 40% before discharge. And the fourth one, it is percentage of contrast-induced nephropathy post-primary BCI. The first BCI, our target regarding diagnosis to wire to be less than 60 minutes, our target to be more than 60%, and the benchmark, it was more than 75% according to data from the European Society of Cardiology 2017. Our achievement, it was comparable, it was acceptable during January, February, and March. We reach about 60%, but after that, during COVID period, after March, at the spike of COVID, you know that according to European Society of Cardiology, the European Society of Cardiology extend the window from 60 minutes to 120 minutes during this period, and give us permission to extend the delay to be less than 120 minutes. So this is exceptional during COVID period. And really, we continue to do primary BCI for all or most of comers to Al-Qasmi Hospital during spike of COVID period. We continue to afford this service for at least more than 95% of all comers. We use 2 or 3 times thrombolytic therapy during spike of COVID period. And this is our achievement in this period, that we achieved 100% of patient to be less than 120 minutes as per mission of European Society of Cardiology during COVID spike. What we learned really from during the COVID crisis, what we learned during this period, we learned a lot. We continue to do primary BCI for all ST elevation comers to Al Qasmi Hospital. No one from our CAS lab team affected during this year. We apply strict measures regarding personal protective measures. We apply also strict measures in CAS lab to avoid any contamination, including fumigation and sterilization. And other indicator, it was in-hospital mortality rate in ST elevation myocardial infarction after primary BCI. Our target to be less than 40%, and benchmark it was less than 40% according to the reference of Mount Sinai in the center of New York of USA. We have to take in our consideration that we counting all patients coming with ST elevation MI. We not exclude patient coming with cardiogenic shock or in hospital cardiac arrest with ST elevation myocardial infarction. Also, we not exclude patient coming with acute heart failure and ST elevation myocardial infarction. So there is no exclusion in our patient coming with ST elevation MI. Our achievement, it was about 2.6% in hospital mortality. The third indicator, it was about ejection fraction more than 40%. Our target, it was more than 70%, and benchmark, it is more than 69%. The fourth indicator, it was about the percentage of contrast-induced nephropathy, post-primary BCI. The definition, it is defined as elevation of serum creatinine of 25% or more from baseline to above the upper normal limits within 72 hours after primary BCI. By this definition, our target, it was to be less than 3.3%, and benchmark, it was less than 2% according to the reference of International Society of Cardiology. In cases from January to July 2020, our percentage, it was 2.6%. It is comparable to the benchmark, and it is less than our target. After that, we get the certificate of, they consider after meeting the committee for 2 days to investigate our performance, our following all recommendations of clinical pathway or steps for 2 long days from 7:30 till 4 every day. We consider us as a center of excellence for management of acute myocardial infarction at 6th of September 2020. And we added 3 KPIs, and we start calculating these KPIs and monitoring these KPIs from September 1, which is the percentage of cases done by radial access. And I can tell you that it is about 98 to 99% of our cases is done by radial access. And you know that this is reflect the complication, because the complication, side complication, it is much less with radial than femoral. Even there is data in the European Society of Cardiology that the mortality with radial axis is less than femoral axis. Also, there is reduction of mortality with radial axis. Also, the fluoro time during procedure, which reflect also the operator experience, patient safety, also, which is very important. Also, dye amount during a procedure, which also reflect operator experience and patient safety. So we added 3 KPIs and we start calculating and monitoring and auditing these KPIs then since September 1st. What we learned after implementation this clinical practice pathway for managing for managing patient with ST elevation, we integrate pathway into a read system, so all documentation are saved now in save area, so we can go back to this data. We can do many of publications. We can learn a lot from this data. We can enhancing also what we learned, that we enhance multidisciplinary team approach in our Al Qasmi hospital, and we standardized all medical services provided to ST elevation myocardial infarction. Also, we can trace any variances of this standardization with any step of clinical pathway in regular monthly meeting to define causes and suggest action plan for that, then monitor this action plan. Also, we can tracing achievement of different KPIs in regular monthly meeting to analyze result and to give action plan and to recruit our data, especially KPIs in results for publication, for improving health services, and also recruiting our data, especially KPIs results for appraisal performance for each operator with confidentiality. And also we suggest new KPIs and canceling some at annual meeting analysis. Also, we success to apply multidisciplinary teamwork through involving other health providers, pharmacy, physiotherapy, nutrition, cardiac educator, psychiatry, either during hospital stay or at multidisciplinary clinic after discharge. What our challenges, what our still we have some challenges, some future plan, which is to afford in-house international team 24/7 days. We still not have in-hospital, in-house interventional team. Also to create network system of North Emirate for hospitals and medical center to optimize ST elevation MI services to afford optimal service at optimal time in appropriate center. And you know that Dr. Arif, he is guiding this project, which is in progress to draw a map for each center in the North Emirate. So any patient come for each center now after finishing this project, he will know to any center where he will take medical services and which medical services he will take according to this map. So Dr. Arif, he is guiding this and still in progress. So I will finish and thank you for listening. Thank you.
Dr. Abdul Majid, do you like to add a comment?
Thank you, Dr. Arif, and thanks to all our colleagues. I think this is great. The amount of learning and that I had over the last hour and a half is amazing. Sharing the experience from Fujairah region, from Al Qasimi, and me being close to our colleagues in Ajman and Maqween and Ras Al Khaimah, kind of puts the picture now together. And I think everyone can learn from the other, and I can see some of the comments that talks about the differences in how people addressed their challenges. But I think I got a few questions here that we can stimulate the discussions. We have about 20 minutes to go over them. And the first I would say is I'm just going to go simple, and then I will go to a more complex scenarios. But if I want to ask Dr. Mohammed Salah, cardiologist in Kelba, and you do have patients who presents to your hospital with STEMI, and you the process of improving the care of these patients, getting agreements with the hospital that has a primary PCI. My understanding is Kelba hospital doesn't have a primary PCI or a cath lab 24/7. So you have to transfer your patient to another place or thrombolize them. How did you address it through your presence there?
Okay. First of all, I would like to thank you, Dr. Abmegid, Dr. Arif, for this organizing this very nice meeting, and all the speakers and what they submitted from their experience. Actually, when I arrived in Kelba Hospital, I found so many challenges to deal with the patient with the primary PCI. First of all, at the beginning in 2017, there was no referral hospital for the primary PCI except Al Qasmi Hospital. At that time, Fujairah Hospital was not yet or not accepting patient for primary PCI. So the challenge in the front of me, yes, Al Qasmi Hospital, they are very nice team there, they accepting the case, but the distance and the transfer and the logistic for the patient to arrive there. So I'm gonna to lose, because yes, we are in Kalba near, geographically we are belonging to Sharjah, but we are far away about one hour from Qasmi. So I started to look out for the challenge to give the thrombolysis to the patient. Then I found that two important challenge for me. The ER emergency room at that time when I arrived, the doctor there and the staff, they were not authorized, or they don't know to make any single intervention with the patient come with acute STEMI. So I have to take the patient from the, and even there was no even the chance to give us thrombolysis in the ER until I transferred the patient to the Sharjah hospital, to Qasmi hospital. And after that, as the things, I started to work on it to improve this situation. I started to implement some protocol with the help of MOH, and we do some focus BDCA. So at the end, I reached to the stage to give the thrombolysis in the right time, even when the patient arrived. Then, after the communication, patient can be shifted to the BCI center once they are available to accept the patient. Later on. What?
So your protocol is a drip and ship protocol.
Yes.
So you give,
yes.
I
give the thrombolysis the patient, and then I shift the patient to the.
I saw Dr. Bassam, looked at all the quality indicator when it comes to a primary PCI side. Now, for thrombolizing patients, when you do thrombolysis, do you measure the door to needle time?
Yes.
And ensure that it's less than 30 minutes. Is that one of your KPIs?
Yes, this is one of our KPIs that I started to address even to implement in my hospital, just to be sure that we give the patient the best chance or the best time to treat him. Then after that, when it started after then 1.5 years, started to have another hospital, Fujairah. They start to accept the primary BCI. So I made all the challenge that once the patient comes to the emergency room, I make the spot diagnosis, and then we contact the Fujairah hospital to accept the patient. And we were able to manage to reach to about, yes, we have some difficulty in logistic, but this is the usual because you have to admit the patient and then you have to discharge him and the patient to be accepted there. But at most of the case, we were able to lead the patient to arrive to Fujairah in a very right time, almost to what the guideline recommended. So this was a good achievement for us. But there is some challenges that we faced also. That I worked on this one. I tried to make a protocol also to make the emergency room to make the diagnosis immediately, and just to contact with the cardiologist, to contact the primary BCI center immediately from the emergency room to shift the patient. So no need to make the admission to the hospital and then to discharge him again or to admit him in the CCU. So this gives us more and more time to reach even less in the recommended time to give the chance to the patient. And thanks God, this was very helpful for us to do like that. But still, something that you find that if the CAS lab is not working, or if, like in the COVID area, in Qasmi Hospital, they did a great achievement really to make the primary BCI for observation. But in COVID area, it was a little bit difficult because in some regulation, MOH, they asked that you have to give the patient a COVID test before you transfer him. So this is at least, then you lose the time for these things. There is nothing rapid to show your patient or to prove that the patient is not COVID negative or COVID positive. So at that time, we thrombolize all our patients in the right time. And I think it was very successful. And on the second day, we shifted the patient within 24 hours after we have the COVID the result to do the BCI. So I think
Thanks, Dr. Mohammed. I think that's great. So what I feel is you've been dynamic and you've been through the drip and ship first, and then now you're adopting a primary PCI, and you're monitoring all your times in terms of when you had the pharmacoinvasive, the door to needle, and when you move the patient, you're monitoring the door in and door out, and you try to get your patient to primary PCI.
Right.
Timely fashion. I just want to switch gear and try to use
Can I comment, Dr. Abdel Majid? Can I comment?
تفضل دكتور بسام تفضل.
In Al Qasmi Hospital, we considered all patients as COVID positive, and we take all protective measures to protect ourselves, to protect patients, to protect the team. So we consider all patients as COVID positive, and we deal with patients accordingly. And we discover many patients after we finish the procedures at the second day that the patient was COVID positive. But fortunately, no one of our team, we take very strict measures of protection. And fortunately, no one of our team are affected in this period.
That's, I think, Dr. Thanks. I think the point of with the epidemic, having it as an excuse to delay the care or not to provide the care for a STEMI patient is not a valid, especially in our country where a lot of the primary PCI sites are well equipped when it comes to protective measures. So we have a lot of PPEs as a teams, and I think we have to ensure that we have a streamlined process for those patients where we minimize or we reduce the exposure of our staff, but at the same time we we provide the care to our patients. Just to switch the topic towards the registry or the data collection, and I thank Dr. Arif at the start when he pointed out that it is time, and I think this is one of the challenges we're facing across the country, is we need to have some sort of a standardization when it comes to what indicators we're collecting. So I know in Abu Dhabi, we do have by our regulator, the Department of Health, there is a certain parameters or KPIs or indicators that is mandatory in all hospitals when it comes to STEMI care that we have to collect, including door in, door out, door to balloon time, and so on. I saw the indicators pointed out by Dr. Bassam through the accreditation. And I think, you know, across the country, I think we need to come with a standard indicator and a way to collect data to ensure that, you know, we learn out of this data before, you know, before using it as a punitive or a penalizing. It's just collecting the data to get better. And I would like to, the insight, what are the challenges to get that done, such a project? You know, cardiologists who are practicing in those hospitals, Dr. Abbas, Dr. Munder, you know, what's your thought? Do you think this is practical? You see patients with STEMI, you know, also Dr. Fabrice, you see patients with STEMI and you manage them either acutely or post-discharge. Do you see a challenge in data collection where this data is going to be used to improve the care? We want to see how can we collect this data, and what are the other challenges you have? If I say, Dr. Abbas, do you see it?
Okay, thank you, Dr. Abdul Majid. I think there is a challenge in getting this data or collecting data. Number one, I think the electronic system that we have is different from hospital to hospital. And patient might start his journey in one hospital, then he will follow up in other hospital. I think if you'll get like one electronic system, one registry, the collection of data will be like unified, will be easy, and the follow-up will be easy. And even there is some important issue, Dr. Abdul Majid, that patients are like moving from hospital to hospital, and whenever going to other hospital, all the workup will be repeated. Like patient will come to our hospital, will go to Al Qasimi after that, and there is some dangerous issue in that also, that they are taking medication from different hospital, and sometimes the brand is different. I notice many patients are like handling with them 2 anticoagulant or 2 antiplatelets or 2 types of statin. I think start a registry, it will help a lot.
I think, yeah, I think this is a very good point. Unified system across for data collection is a challenge, and I think it's across a lot of other healthcare systems. You know, should you use the EMR or should you have a standalone system or platform where everyone puts the data into that platform? I don't know, any other of the other colleagues would has any points to add when it comes to the registry?
If I may, I can speak about our experience.
Yes, sir.
Back in Italy, when we developed our nationwide system for collection of data, actually not only the STEMI cases. So most of the challenge is related to the data input. You know, every data input brings with him some errors. So you should find out a way to create one single endpoint. Have to be even feasible for the doctors, so they don't have to repeat the same process every time they input data inside one system. And so what we did in Italy was, okay, let's create a common platform for all the cath labs. That was done by Interventional Society of Cardiology. And with this system, you provide even your report of your PCI. So with a single input, we reported our PCI and we collect data all together. Then sure, if your electronic medical record hospital can be connected and data can be extracted directly, is fantastic. But unfortunately, this is the point and the weak point of every data collection. Make different software speak together. It's very challenging. You need a lot of back work. It's very expensive, but it's the key point. So try really to minimize the number of data inputs you have to do. But really, when you get this data and you collect all of them together nationwide, you really have the great picture, and you really can analyze a lot of things. Yeah, sure, you can do KPI and performance, but you can do a lot of research. And think about the SCAR project. The SCAR project in Sweden, no? They were the first one collecting all the data, and they really came out with amazing results after 5, 10, 15, now 20 years.
Great.
So I think it's a great effort. This country should do. You have the we have all the quality to do it, and it's a great project. One of the most important, I think. Thank you.
All right. So I think, you know, I think there's a consensus across the board that there is a need for data collection. The question is how to do it and how to address the challenges on getting that that project moving. I don't know, Dr. Arif, I think he is.
Yeah.
سمعني دكتور عارف.
Yes, Dr.
Yeah, I don't know. I mean, what's your thoughts? I mean, people are talking, our colleagues here are talking about unified system, about a simplified registry for, you know, a platform, a single input, you know, to avoid duplications and so on. يعني, how can we move it? And every time we sit, we talk about it.
You know, Dr. Abdul Majid, actually, first of all, let me say, I'm so happy to see what I've seen today. That was really remarkable data being presented from so many dear colleagues across the Northern Emirates. This is something that for me to see this kind of across the country. Now, when I looked at the numbers, the figures, you know, just simple adding the figures, we do something like 500 to 600 primary PCI a year. I heard that SKSA is doing something like 250 to 70, and another 150 from Ajman, and 100. So we are talking about 1,200 cases annually. Yeah, that's not a small number. We are talking about 1,200 MIs, and mainly we are talking about ages between 35, as Dr. Bassam presented, to 60. So this is really something of great importance for us as cardiologists to address and take care of. Now, we started primary from 2003. I can tell you we started 2003, our first primary case. And it's been a long journey, 17 years. And looking back to the data presented by Dr. Hussein, that things can move slowly. That's a fact. We can't overcome this challenge. Time is a factor, but we should start somewhere. I mean, we can't just look around and say, well, there's challenges. EMR different between Abu Dhabi, Dubai, Northern Emirates. Now things are getting closer and closer and closer. That is something promising. So I won't be looking at it in a pessimistic way. I'm totally optimistic, and I'm more optimistic to see every center having its own data. So all what we need is to network, to integrate those EMRs across the country, and you get this. They are already there. The informations are available, and we could really support this registry and find a way to present this data, which has great value, by the way, as Dr. Fabrizi also mentioned. This will reflect in the future planning and strategic management of STEMI in our country. Each country has its own unique features, unique geography, unique things. You know, I had a chat with Dr. John Fajade, and we applied for a Stand for Life initiative a couple of years ago. And that was at that time apparently a little bit prematurely, because we had still not so far, we were not so far with EMR. But now, by time, it takes time to implement this kind of digital electronic records. We have them now. All what we need is really to bring them together. Somebody like interventional group or whoever will take care of this. And I'm more than happy to support this, and the group with me, you and our friends, colleagues. Everyone is going to be supportive in this, because it's going to help us all at the end of the day. It will help our patients. It will improve our outcome for our patients. So I think we are on the right track, and there is another project from Ministry of Health regarding in the kind of integration regarding the transportation, the support of national ambulance among the centers in the Northern Emirates. So this, I think, within a year, unfortunately, COVID came in between and disturbed the whole plans that have been on progress. But I believe in the coming 2 to 5 years, we have very good promising plans to improve this. So here, I would like to hand over back to you, Abdul Majid. I hope your support also in this. I'm sorry that nobody from Dubai is here available, but I'm sure they have very advanced also data, and they are well-established database that they have, and that can be easily integrated with our systems as well. Thank you.
Great. No, I think, you know, I agree with you, and I like that paper, you know, Dr. Hussein showed us. I mean, I think we got to start from somewhere, and you know, either when it comes to the network, to connecting the hospitals, connecting all the different healthcare providers, the pre-hospital care. I have a lot of questions around the pre-hospital care and other questions or points that's related to you know, to establishing a network and communicating between, you know, between different hospitals that has a cath lab or doesn't have a lab, between and questions related to thrombolysis. Just because of the time, I think we need you know, we need to close, but I think that, you know, there is more to work on. We achieved a lot, I believe, you know, when it comes to the region, listening to, you know, to all the experience, but also on the other side, I think there is a lot also to work and progress, and definitely we will you know, will reach our target. Remember that, you know, the patients were taken care of, from what we saw from the registries, are from the data presented, sorry, are young patients. You know, the average age is 49, so a lot of young patients that you're taking care of, and the impact you're having on the life of those patients is many years of life saved. And remember that most of our patients are workers who has families behind them. So, you know, when we take care of these patients, you know, we have you know, the service you're providing is a service that impacts a lot of people behind this, you know, these patients. So we have to do this, and we have to, you know, to put every effort to ensure that the service reaches every, you know, every person who is suffering from this syndrome. Before we close, I don't know if Dr. Arif got anything, but I would like to thank all the speakers, Dr. Bassam, Dr. Naeem, you know, Dr. Hussein, Dr. Fabrizio. I would like to thank Dr. Abbas and Dr. Salah and Dr. Munder for their, you know, presence and participating in this. Dr. Arif, of course, your leadership in helping to, you know, to push this forward at the level of your hospital and at the level of the Ministry of Health, and also at the level of the Emirate Cardiac Society is well appreciated. I'd like also to thank Sahar for from the medical office, who helped in putting this together and coordinating it. Thanks to and also Luis Bain, who worked also with Sahar on this. They over the last, I think, 2 months, they have been putting this program and calling individuals and speakers to ensure that we have this program put together. Thank you all. I would like also to thank our sponsors from
GE&B Brown.
GE&B Brown. It's the end of the day. GE&B Brown for their, you know, generous, unrestricted support. Thank you. And Dr. Arif, the mic is yours if you have any closing remarks.
Well, Khalid, I think that was a tremendous meeting. We had really a deep insight in all kind of STEMI management in the Northern Emirates, and looking at it, it makes me really feel happy. Finally, we have really centers with high level of management for our STEMI patients. So our patients should be happy and sleep safely. Thank you very much, Abu Khalid, for this, and looking forward for future more collaboration with all colleagues. Thank you very much.
Thank you.
Thank
See you guys.
Assalamu alaikum.
Salam.
Thank you, everyone. Thank you.
See you guys.